Hey everybody, so we're gonna give just a couple more minutes, let some more people go and jump in. So we got Alberta, Toledo, Ohio, Dubai, Iran, Louisiana, baby. All right, very cool. Saudi Arabia. All right, coming in from all over the place. Awesome. All right, everybody, so let's go ahead and get into it. One coming in from South Carolina. Awesome. Everybody's popping in. Cool. So let's get into our case study. So hopefully everybody was able to see the preview that was out on social media, and we're going to go from there. But let's go and review anyways. So you were dispatched to a 10-year-old having difficulty in breathing at the local elementary school. Dispatch advised you that the patient was outside at recess playing basketball, that the patient began coughing and has been experiencing a continual worsening episode of difficulty in breathing and was going to be in that nurse's office. So kid was having shortness of breath, coughing, and you found them in the nurse's office attended by the school nurse. You find they're kind of sitting in a tripod position, coughing, kind of appearing pretty generally ill. They got a GCS of 4, 5, 6. Their airway is patent because they're coughing. You don't hear any other crazy adventitious sounds. Um, they're speaking in 2 to 3 word dyspnea, so they're only able to get out a couple words for the gasp, taking more coughs and everything. Their skin is cool, dry, and pink. You didn't notice any disabilities, and the only really environmental concerns is it's pretty cold outside. It's wintertime, 40 degrees Fahrenheit or 14 degrees Celsius. You got them on the monitor, and this was part of your secondary assessment. We found them with a heart rate of 119, a sinus tach. They were 92% on room air, and we noticed in a pleth that hey, we've got a good pleth, so the perfusion is getting there. They're just hypoxic with the amount of blood getting to their digits. End tidal was 33 with the respiratory rate of 30. And we can see end tidal qualitative and quantitative measurement, and 98/63 was their blood pressure. Got an oral temp of 98.5 Fahrenheit or 37 Celsius, and their blood glucose was considered normal. When you listen over lung fields, everything is silent. You aren't unable to hear anything. The patient's kind of breathing fairly shallow, coughing sporadically, and just auscultation. You can't hear any movement or really any sounds at all. The abdomen soft, pliable, it's symmetric, non-tender, nothing noted there. So you're unable to auscultate lung sounds. You start noticing some accessory muscle use, having a hard time breathing, and there is no known medical history. The the patient's attended by that school nurse, no patient or no family around. The nurse went, checked the medical records, and has no notable medical history at all. So you were posed with these questions. What was your differential diagnosis? What would be your immediate treatments? And overall, how would you handle this situation? So you've got a minor with no parent present. So where does consent fall into place there? Yeah. So the comments that were coming in and whatnot kind of got a variety of mix of possibilities of formulations of a differential diagnosis. Okay, so one coming in was anaphylaxis. So we start considering, well, they were outside and then they got short of breath. Okay, so we started thinking about anaphylaxis. Well, in anaphylaxis generally comes, difficulty in breathing. Yes. And then we can notice some urticaria, some welts, and then generally worsening shortness of breath, and then following with hypotension. But We didn't really have any of the hypotension there, just the shortness of breath. Skin was pink, warm, seemed to be perfusing okay, just not oxygenating well. So we can kind of rule out anaphylaxis. And then we go with epiglottitis. Hey, that's a pretty common pediatric issue. Even the patient being 10, a lot of the research showing now that epiglottitis, used to be only up to about the age of 6, but now up through the age of 12 is pretty common for pediatrics having complications. But inevitably with epiglottitis, the big thing is like, yeah, they have body positioning. They're generally leaning forward, trying to leave any pressure on their larynx or the oropharynx, and excessive salivation because it hurts the swallow. But we didn't really have any of that. Additionally, in this, that they're generally febrile because it's an infection, but the patient was afebrile, no excessive drooling, no crazy adventitious sounds that we hear, such as stridor. So we can kind of rule that out as well. Then went with pneumothorax because, hey, their lung sounds were absent. We couldn't hear anything, but it was also bilaterally that we're just not able to hear any volume or anything coming through. Then you in that, if we're at the point with the pneumothorax, if we're getting absent lung sounds on one side, then inevitably hypotension is going to go into that, and it's a tension pneumothorax. But perfusion was okay, just unable to hear anything bilaterally, so we can kind of rule that out too. Then we get on to croup. Hey, the patient's coughing. Hey, that's a big sign of croup is that seal-like barking cough. But then you could hear in the video clip, hopefully, that it was just kind of a dry, non-productive cough. Didn't really have that deep, raspy sound to it, like that part of the upper airway was inflamed or irritated, like you may get out of epiglottitis, or croup, just that larynx being irritated. We didn't really hear any of that stuff, and also they weren't fevered. Okay, so in croup, it's also a form of infection, so they most generally always have a fever between croup and epiglottitis. Fever between the both, sometimes it can be more one side than the other, just depending on other things going on. Okay, so we can kind of rule out croup. Well, then that leaves us with asthma. And hey, this is where most people went with that we have shortness of breath, they're afebrile, they were outside in a cold environment, and hey, it stimulated some asthma conditions. And hey, that's kind of what we went with here, especially when we saw that shark fin appearance on the waveform. That is very indicative of bronchoconstriction going with asthma. Okay, because if we think about, let me draw it out a little bit bigger here. So if we think about that waveform of what it is, okay, it's generally a good waveform should look something more like this. Because as we begin to exhale, all that CO2 comes out very quickly. And that's what causes a sudden spike up on the qualitative measurement, our waveform. We'll see that sudden increase in CO2, and then a little bit of residual still comes out. We inhale and it goes away. Well, with asthma, the issue is air escaping. So that CO2 and overall volume is getting trapped, and it's a slower release of all that air volume than what we would normally see. So asthma it's a hyper responsiveness or a hypersensitivity to something. A lot of asthma flare ups or exacerbations are caused by various allergens because people who have asthma have allergies, they just kind of go hand in hand. So, some of the biggest ones is dust, insects, animals, flowers, cigarette smoke, environmental things. So, we could see a lot of these issues, like if we're looking at seasonal, springtime, everything's going into bloom. Um, we'll start seeing some of those flowers and pollen and stuff going and can kind of trigger some of those conditions. But then also cold air and exercise, anything that's kind of changing Turbulence or the quality of the air coming in, such as cigarette smoke, poor quality, irritates those already sensitive bronchioles and is going to cause those issues. Okay, so cold air in this scenario is kind of where that was leading to. The patient was outside in the cold air, exerting a lot of energy, and that cold air has exacerbated their asthma conditions. And in those pediatric populations, sometimes asthma is the thing that they grow out of, but sometimes it's something they had as a child that always kind of stays in their body and is just dormant, and then eventually their body becomes hypersensitive to certain things, and then asthma rears its ugly head again. And because remember, be mindful of that. Like in this scenario, the nurse had the packet, no medical history on it, and without putting you in like a paranoid thinking sense, like I said, that sometimes those kids can have asthma and they're believed to have outgrown it, which can be the case in some. And again, sometimes they can remain dormant and just come out. And sometimes patients aren't getting diagnosed with asthma until their early teens or even into adolescence or adulthood. All right, so some pathophysiology, what's happening here? Immunoglobulin E at the mast cell will produce your white blood cells. So that allergen gets exposed into the body in a in other asthma, not necessarily in this scenario, but say this environmental concern, they're allergic to pets and whatnot. This allergen's coming into the body, and those white blood cell counts, interact with that allergen continually, and they change things, and they just know how to interact based on this. So anytime those mast cells are exposed to an allergen, it just kind of stores a memory of how it's going to react. And same thing goes into like anaphylaxis. Well, then the way I like to describe it is when an allergen comes in contact with a mast cell, it produces the three stooges. Okay. Don't be mindful. I may botch the pronunciation of this, but we have histamine is one of those released, prostaglandin, and the leukotrienes. Okay, those are the three stooges that get released by the mast cell in reaction. So the mast cell, like, hey, there's an allergen. I see it. I've been exposed to it. This is what I do every time, and then it releases these. And like similarly, in the case of anaphylaxis, sometimes it produces too many stooges. So those three stooges go in and they go to those bronchioles and they cause this like spasming and inflammation of that bronchial wall. So instead of having this nice, open airway and nice smooth bronchial muscles, the bronchioles they kind of spasm, they get irritated, and once that bronchial tissue becomes inflamed and irritated, mucus gets produced as well. So if you can kind of see the yellow highlights in there, that would be the mucus production within those bronchioles. So those three stooges come in, irritate those bronchioles, and then hey, that's what causes that inflammation and constriction and spasming of the bronchioles. Comes coming in. Uh, yeah, this class will be is being recorded, so it'll be posted out to social media and everything later on YouTube and all the platforms that's going live to now. The recording will also be out there later on if anybody has to go on calls or whatnot. All right, so like in this scenario too, the cold air has come in, we've inhaled that cold air. Well, as air is cold, it becomes very dry. So you think about in the winter months, or if you ever ski or do anything, cold months, it's inevitable we got to carry chapstick with us because our lips get really dry. So our lips are getting dry because the air around us is just so dry. So it dries out the membranes of our lips. Well, same thing. If you already have hypersensitive bronchioles and you're starting to inhale this cold air, it can just cause that hypersensitivity to those bronchioles, and again, cause them to inflame, to spasm. And when they spasm, they start producing mucus, such as in this scenario. That cold air has come in, it's all dried it out, and that those bronchioles become irritated, like your lips get sore, they're dried out, and it just really irritates them, so they spasm. And then, so what's happened here? This is, a normal, as best as I can draw. Air comes in through our trach into our bronchioles, bifurcates, splits, good smooth air in and out. But what happens here is these bronchioles, they constrict. Okay, so the issue is air is having a hard time getting out of the body. So instead of having a normal sized lung, they stay hyperinflated because the air is becoming trapped. All right. So in this, that's why you're going to experience that or hear that wheezing in the acute phases of bronchoconstriction. It's air going through a narrow pathway. So if we think of that as we take a balloon that's inflated and we grab the end of it and we hold it tight, create that narrow passageway. It does that sound. So it's air going through a narrow passageway creates the wheezing. So exhalatory wheezing is what we'll generally hear in the acute phases or the exacerbation phases. But also in late signs of this, like as in status asthmaticus, like nothing has been able to break it. Granted, no interventions have necessarily happened with this kid yet. So that's why they can be silent chested because nothing's been happening. So the air is coming down in here and it's getting trapped and it's not getting out. So when we auscultate, we're listening to air coming in and going out. But if these are significantly tight, the air is coming in and it's getting trapped. So that's part of the twofold reason. The child is coughing because that's kind of our reflex that our body has sensed that there's a buildup in pressure in there. And since exhalation is a passive process, there's no, we inhale, it's an active process, diaphragm pulls their air down in, but there's nothing in there to push air out. So it's kind of a reflex from our body to start coughing. The same way applies if we take a drink of something and we sense it goes down the wrong hole, we cough and hack, we gag because of that stimulation. Well, the body has sensed overpressurization of those lungs and nothing's coming out. So it's kind of a reflex, a barrier reflex, to cough as your thoracic cavity squeezes to try to push air out the best that it can. But if the lungs are completely full and they can't really get air out, you're not going to hear any air coming in because the lungs are just completely full. So you're getting minimal air volume exchange in those patients who are in extreme conditions of bronchospasm. Uh, yeah, and for silent chested asthmatics, yeah, that is definitely considered a severe asthmatic attack. Okay, so silent chested asthmatics, we think about this concept. If we can't hear any air going in or out, we think about how complicated that could be if we're trying to give them a nebulizer treatment. So we give them a nebulizer treatment, and if we can't hear any air get in when we're nebulizing that medication, it's not getting into here. So we may only be exchanging air here in that dead space. That dead space does not do any type of respirations at all. There's just a little bit of ventilation happening here, but no cellular respiration happening. So it's inevitable that in these they start having silent chest, you can't hear anything, or maybe up here on the apex of the lungs you hear a little bit of air movement, but it's just diminished everywhere else because the only part that's actually doing any true air movement is up high. So for the management of these patients, of course, the first we're going with oxygen. Any patient who presents with difficulty in breathing, shortness of breath, we're going with oxygen right away. Okay, so number one, oxygenation. Okay, no matter what their pulse oximetry says, if they present, you're looking at them in their general pressure, airways patent, breathing, 2 to 3 hour dyspnea, doesn't matter what their pulse oximetry says, give them oxygen for the shortness of breath. Okay, and we're going to go with, 15 liters for that patient who's in, respiratory distress, that are in nearly respiratory failure. So all these things that we're going to intervene with are quick action, short duration things to intervene with. Next is going to be a combination of buterol and or atropine. Okay, going with both of them because for twofold, the albuterol is going to cause bronchodilation. So in that episode of having the bronchioles constricted, it's going to go and open these up to one, allow air to come in, and all that other air that's already been utilize all of its oxygen to get the bad air out and to get new air in, and also allowing those medications to open up the bronchioles, allowing the oxygen to assist. Okay, so when we give oxygen here, so at our 15 liters, we're also that increases PEEP a little bit. Okay, so that little bit of flow comes out, adds, a couple centimeters of water pressure to help open up those alveoli. And then this is going to cause bronchodilation from the albuterol. And the Atrovent, its job is to kind of help with the secretions. Okay, it's going to help the secretions. It reduces the inflammatory responses of those bronchioles and just kind of helps the albuterol do its job. Okay, so you'll see those silent chested asthmatics that they're coughing because all that air is built up and they're trying to cough and expel and expel and expel that air, but it's just stuck. And then epinephrine. Okay, so in the little populations, like neonates, toddlers, infants, there is racemic epi, but that's not something that's routinely carried in EMS. There's always comments about doing nebulized epi and doing our modified racemic epi, but generally what we're carrying between anaphylaxis or cardiac epi, anaphylaxis epi of that 1 to 1000 is still not nearly concentrated as what a mixture racemic epi would be. So with what we're carrying in 1 to 1000 isn't truly a racemic epi. But in this event, if they are so bronchoconstricted that no air is moving, this is not really going to help much. Okay, so a routine thing that you may see is you go to home and it's a kid or somebody with asthma, they've been taking their meter dose inhaler and it's just not working. And that goes back to the issue of not enough air can get down in. So if your meter dose inhaler, it's just relying completely on diaphragm to pull it down in. If we're going to nebulize medication, just as a non-rebreather increases PEEP slightly, putting that on a nebulizer is going to increase a little bit more pressure shoving it in. So as you're trying to take a breath in, not much is happening. The little bit of pressure that nebulizer creates is going to assist in that medication being basically shoved down in. Not as much as like what CPAP would do, but still inevitably more than if you have an inhaler and you're trying to pull all that down in on your own. This creates a little bit more push together. But if you have epi, it's good because the onset of that is very, very quick. So onset of epi IM is within a minute that it's going to start opening up the bronchioles. Okay, especially in kids. Kids tolerate a fast heart rate and all those alpha effects better than the adult population does. So if they're at that point where there's no air exchange at all, this may be completely life-threatening immediately to where that might end up being the go-to. So in this case of silent chested, no air moving, if you're going with this route and it's not working, doesn't mean you have to stop this to go to this. Okay, so you could be taking a nebulizer, you're not seeing any kind of marked improvement. And then knowing that our onset of action of both of these is less than a minute. So less than 1 minute, albuterol Atrovent should be having some effect. Whether like the coughing's getting better or they're able to take a breath, their 2 to 3 word dyspnea turns to 3 to 5 word dyspnea. They're able to talk, their pallor's going away, the cyanosis is going away. But if it's not, you've got this in your back pocket that you could go with epi 1000 IM to immediately open up those bronchioles, work really quick so this can go in and help keep them open up. And with CPAP, okay. Most things considered, CPAP is not predominantly done in a lot of EMS systems pre-hospital for pediatrics. In places that do utilize CPAP, they're only kind of suggesting to start with around 2 centimeters of water. Whereas in adults, we're going like 3 to 5. But CPAP for kids, it's kind of iffy washy. So, like this patient at around the age of 10, not probably pubescent age, gonna be difficult and are still very sensitive, smaller lungs. So if we think about going on this lower side, and as I said before, a nebulizer, it has been shown to do around 1 to 2 centimeters of water pressure just by a good nebulizer. Okay, so if you think if you actually wanted to get more, something else that you could do is supplement that with a nasal cannula. Okay, so if we need just a little bit more peak pressure to help get that medication in, but we're not going the CPAP route, put a nasal cannula on and put that non-rebreather on, because each oxygen delivery, it's coming out of a high pressure system anyways. So if it's coming out of a high pressure cylinder, inevitably it's going to put a little bit of pressure into our body anyways. So supplement that nasal cannula with that non-rebreather to help assist PEEP, keep that alveoli open, get the medication down in where it needs to go so it can go into effect. So those are things we're going to do quick action because they have quick onset of things, or things that are going to help for the longer duration are such things as our steroids and mag sulfate, and other things for antihistamines. One I didn't put a picture in here is like Benadryl. Okay, it's a consideration in there since one of the three stooges is histamine. So assisting in that histamine release, go with an antihistamine such as Benadryl if it's in there. But it's a consideration, but it's not really a main staple like steroids or mag sulfate is going to be. Okay, so all those are going to help with reducing the inflammation overall with the steroids. It kind of eases up the irritability that those three stooges are going to cause the muscles. So it kind of blocks those responses from those three stooges and says, hey, leave it alone, let the muscles ease up, let them do their thing, kind of go back. It's going to help prevent that bronchoconstriction from happening again and assist with maintaining good tone of those bronchioles and keep them open and overall reduce the hyperreactiveness and preventative things. So those steroids really help fight the three stooges. And then mag sulfate. Mag sulfate is a smooth muscle relaxant that's given as a drip. Okay. So in these two, these are going to be, these can be IM or IV administered medications, but we're looking, onset depending on which medication is, of these, we might be looking at an onset of, 15 to 20 minutes. So yeah, the patient needs these, but oxygen, immediate effect. Albuterol and Atrovent, almost immediately. Epi, pretty much immediately. Get those on board fast so they'll react quick, and then you have these steroids are going to act in and help with the prevention thing. As the onset goes, it's going to prevent those things from coming back, and about the time those other ones wear off, these are going into full effect. The mag sulfate, same thing. It works a little bit different way, but you're looking 15, 30 minutes depending what they do, and considering that goes in as a drip. Once that drip kind of starts getting about halfway through is when you're going to have that peak effect. So given as a drip, so it continually holds in, dilates the smooth muscle, the bronchioles, and keeps everything nice and opened up. And I like to explain all these things as like a timeline. Okay, so if we're doing, an oxygen, a nebulizer, and even epi. Okay, those things, we give them here, and their onset might be here in our timeline. Okay, so we give them, they react pretty quick, and then their duration is going to be kind of hit their peak effect. Let's say 5 minutes in, everything's at its peak effect, then it kind of starts to slow down. So if we start, we gave everything here and we realize, hey, this isn't necessarily working, we can do another nebulizer. So if we think, hey, our nebulizer treatment has its peak effect, at about that 5 to 7 minute mark. So here we give that nebulizer, we're not really seeing any marked improvement. Well, we know, hey, it should be at the best it's going to be with this dose of a nebulizer right here. So now we need to maybe start considering to get another nebulizer ready. So we keep giving that medicine so that this gets drawn out a little bit further. So now we're out here like 10 minutes. Well, if we're out here at its about peak effect of adding that extra medication and we're not seeing any additional improvement, that's when we start thinking about those longer treatments of your steroids, your drips, and whatnot. So then out here, like, okay, well, we've on to our second dose of albuterol and Atrovent. Not much is working. This one we can start thinking about steroids and whatnot. So when the steroids are going into being administered here. They're hitting their kind of peak effect here, and they last for a pretty decent time. All right, so then this really prevents, um, the patient going up, getting better, getting worse, going up, getting better, getting worse. We pretty much want to maintain that our medicine is at peak effect throughout. So that's why we kind of our sequence goes into play. And what's important, understanding the pharmacokinetics of peak onset dosing, half life of the medication. So we don't have these big waves of getting good, getting worse, of the medicine wearing off, and then we're behind the eight ball. So just keeping those interventions going at that straight pace. So a couple things to note is I know a lot of people want to talk about ventilating the patient. Well, they're short of breath, they're breathing shallow. But if our issue is air's being trapped, be very, very cautious of providing manual ventilation to this patient because you're going to increase barotrauma. If the air is being trapped, the air you push in is also going to be trapped. So very cautious if it comes to ventilating patients. The final part. Okay, so what to do with this kid? There's no parents present. There is a school nurse there that is tending to them. So how do we handle this? Do we have consent? So as a minor, they cannot essentially refuse that transport. And again, in a life-threatening situation like this, um, hopefully no parent's going to call and say, "Don't take my kid." But we think about who's there. A school nurse or a teacher. They act in lieu of a parent. That medical for that Latin phrase of "in loco parentis" means in lieu of a parent. So, a teacher, a nurse, a bus driver, a coach, another adult that's just taking over them legally becomes in loco parentis. So they can act on behalf of the child. If you're in this event and there's nobody around, they just friends called and at a local park, there's no adults around, it's only kids. That is, the consent that is needed because they're a minor. If the patient were unresponsive, that is implied consent that they need to go. But your kid's sick, needing to go to the hospital, saying yes, take them to the hospital, that is the express consent. Okay, so you have people like nurses, bus drivers, coaches, immediate family. Those are ones who can make those decisions for them. Okay, so that is in loco parentis, people who act on behalf that are not the actual legal guardians of them, but temporarily they are the legal guardians of them while they're at school or in their custody or responsibility. For such. Yep, solid question. So cool. So that pretty much wraps up our case study on the status asthmaticus of his kid. So remember, quick onset actions of medications, quickly intervene, doing those good assessments. If you're hearing those kids having those dry, non-productive coughs, could be some asthmatic issues going in or something as simple as sinus drainage. But if you're hearing that silent chested where no air is being heard going across the bell of your stethoscope, that is a fairly life-threatening emergency because there's no ventilation nor respiration really happening. So quick interventions in them before they deteriorate. So thanks everybody for tuning into this case study. Again, this is going to be recorded and will be posted on social media later. If you need to go back and revisit it again, everybody stay safe and take care.